A 36-year-old male was brought to A&E in cardiorespiratory arrest. No other history is available. I am showing you an axial non-contrast brain CT scan. Describe the findings.
Okay. Looking at the images. The axial non-contrast CT scan demonstrates diffuse, symmetric, low-attenuation changes throughout the cerebral hemispheres and brainstem. There is complete loss of the normal differentiation between the cortical gray and subcortical white matter. Generalized sulcal and cisternal effacement is present, indicating severe diffuse cerebral swelling and edema. The cerebellum appears relatively spared, retaining normal density in contrast comparison to the severely hypodense cerebrum. The diffuse reduction in brain density makes the normal dural reflections and major cerebral vessels appear abnormally bright and prominent.
I am showing you axial brain CT scans of two comparison cases showing subarachnoid hemorrhage. Describe their findings and distinguish them from the index case.
Okay. The first comparison CT scan demonstrates an acute subarachnoid hemorrhage, showing high-density blood filling the suprasellar and basal cisterns. This is accompanied by dilatation of the temporal horns of the lateral ventricles, indicating early obstructive hydrocephalus. The second comparison scan shows extensive subarachnoid hemorrhage filling the sylvian fissures and sulci, with intraventricular blood extension and a large aneurysm at the left middle cerebral artery origin. Unlike these hemorrhage cases, the index case shows normal CSF density in the basal cisterns, with hyperdense vessels appearing prominent solely due to surrounding cerebral edema, representing a pseudo-subarachnoid hemorrhage sign.
What is the diagnosis? And explain the pathophysiology and the classic reversal sign.
The diagnosis is global cerebral anoxia, secondary to cardiorespiratory arrest from severe asthma. Global cerebral anoxia, or hypoxic ischemic brain injury, occurs following prolonged severe hypoxia due to arrest, drowning, strangulation, or status epilepticus. The cortex and basal ganglia are highly metabolically active and selectively vulnerable to hypoxia, developing rapid cytotoxic edema and hypodensity. The cerebellum and brainstem are relatively resistant to hypoxia and retain their density, creating a reversal of the normal gray-white density relationship known as the reversal sign.
Discuss the clinical implications of the pseudo-subarachnoid hemorrhage sign on CT and its diagnostic pitfalls.
The pseudo-subarachnoid hemorrhage sign is a well-known pitfall where diffuse cerebral edema makes the tentorium and cerebral blood vessels appear hyperdense relative to the swollen hypodense brain parenchyma. On first inspection, this can easily lead to an erroneous diagnosis of acute subarachnoid hemorrhage. To avoid this error, one must carefully measure the Hounsfield units of the basal cisterns, which will show normal CSF density in pseudo-subarachnoid hemorrhage, but will be high density in true hemorrhage. A mistake in this direction can lead to unnecessary high-risk angiographic investigations in an already critically ill patient.
Explain the diagnostic sensitivity of CT for true subarachnoid hemorrhage and the appropriate further management.
In that case, for true subarachnoid hemorrhage, CT is 90% sensitive within the first 24 hours, but sensitivity drops to 50% at 1 week. Therefore, a normal CT scan does not exclude subarachnoid hemorrhage, and a lumbar puncture looking for xanthochromia must be performed if clinical suspicion is high. As a radiologist, I would recommend immediate clinical correlation, checking pupils and brainstem reflexes, and supportive intensive care management for the cerebral edema. I would also recommend obtaining a brain MRI with diffusion-weighted imaging and MR spectroscopy in the subacute phase to assess the prognosis and extent of cortical necrosis.